Hello, and welcome to the Clinical Care Options and Practicing Clinicians Exchange Infectious Disease Podcast. I'm your host, Kim Neely. In this 3-episode series, we'll explore uncomplicated UTIs from 3 different perspectives: family medicine, infectious disease, and emergency medicine. In the first episode, I'm joined by Dr. Richard Colgan, a family medicine physician from the University of Maryland School of Medicine in Baltimore. He will share his insights on the burdens of uncomplicated UTI on patients. To follow along with the accompanying slide set, please visit the link in the show notes for this episode. Now, let's get started and hear what Dr. Colgan has to say on the best practices in assessing uncomplicated UTIs to improve treatment and reduce patient burden.
I'm going to just talk as an overview about this underappreciated common infection. I like to think of UTIs as quick win because I think to myself, there's very few instances where a primary care clinician can walk into a room and within about 8 minutes, getting a focused history, physical exam, urine dipstick, you can almost have a great assuredness about what's wrong with your patient, what ails her, and also give her a medicine, which a study I did showed that they'll start finding relief within 36 or 72 hours. So I call bladder infections quick wins. The epidemiology and disease burden, it's the most common bacterial infection requiring medical care, accounting for about 7 million office visits. It's the most common reason why a woman will be prescribed an antibiotic, a big financial burden to the country. The pathogenesis you see before you is ascent of the bacterial pathogen up the ureters, largely gram-negative, largely E. coli, followed by some other things. Prevalence of UTIs varies, but overall, 12% of women. By 24 years of age, a third will have been diagnosed with a UTI. By 32, a half will have been diagnosed with a UTI, with the lifetime risk of UTIs being about 50% in women. One challenge I would like to pose to you is when you see your very next patient in the office with a urinary tract infection, force yourself to say, is this uncomplicated or complicated? Because it makes a difference. There's a difference in how you evaluate an uncomplicated UTI, and there's a difference in how you treat an uncomplicated UTI compared to a complicated UTI. So let's just go over uncomplicated. This is basically your honeymoon cystitis type of infection, a young female who perhaps after sexual activity says she has burning with urination. That's the most common scenario, but it can occur in patients with normal unobstructed GU tract with no history of recent instrumentation. It's more common in sexually active women, non-pregnant women. The symptoms are confined to lower urinary tract infection. Dysuria, urinary frequency and urgency is typical. Those are LUTs, lower urinary tract symptoms, and they may have suprapubic or flank pain. I don't want to imply that all bladder infections are following sexual activity. I probably misspoke there, but just to say that that old term honeymoon cystitis was one example of why a young lady may get a bladder infection. Now, complicated occurs in women and men of all ages. They typically have, by definition, some associated structural or functional urinary tract abnormality, a stone, a stent, a calculi, a neurogenic bladder. Maybe they've had a gunshot wound to the spine. Maybe they're a transplant patient, maybe they're pregnant, maybe they're a male, maybe they're diabetic. These are all complicated urinary tract infections. They too may have LUTs, lower urinary tract symptoms of frequency, urgency. They may have suprapubic discomfort. They may have flank pain as a complicated infection, hematuria, fever, chills, or be systemically ill. That's a complicated urinary tract infection. The etiology is gram-negative organisms. E. coli leads the list, be it uncomplicated at 75% or complicated at 65%. So when you're thinking urinary tract infections, you're thinking gram-negative rods typically. And risk factors for urinary tract infections, you see there before you: sexual intercourse, use of spermicide plus or minus a diaphragm, poor hygiene, family history of urinary tract infections. So if a woman's mother has a history of recurrent urinary tract infections, she herself may then have that as a risk factor. So a maternal history of urinary tract infections can be important. Pregnancy, urogenital structural issues, like I mentioned, stones, stents, catheters, and urinary catheterization. So these are risk factors for urinary tract infections. Uncomplicated UTI, how do you make that diagnosis? Again, it's a premenopausal, non-pregnant female with no known neurologic abnormalities or comorbidities. Symptoms are LUTs, as I mentioned, dysuria, frequency, voiding of small volumes, perhaps urinary urgency. Sometimes hematuria can occur. Suprapubic pain is not classic, but it can occur as well. And then on exam, the exam is typically normal, or maybe some mild suprapubic tenderness. You'll typically do a urine dipstick in your office, maybe a urine analysis if you have that advantage to getting a full microscopic evaluation. And then the big question is urine culture. We'll talk about that. We'll talk about when do you get urine cultures for uncomplicated urinary tract infections. Typically, you get urine cultures for complicated urinary tract infections or recurrent urinary tract infections, or when you're not sure, is this a urinary tract infection at all, an atypical presentation. So the physical exam is typically normal in uncomplicated UTIs. Consider pyelonephritis if your patient looks sick, has diaphoresis on the forehead, is febrile, tachycardic, or has costovertebral ankle tenderness. If they look sick, then that's perhaps not a simple case of cystitis, right? So we have to look at our patients. Diagnostic testing, urine dipstick via a midstream clean catch with proper technique, preferably. On the urine analysis, you're going to look for nitrites as evidence of reduction of nitrates to nitrites, as certain gram negatives do. And you'll look for leukocyte esterase as a sign of white blood cells in the urine. Urine culture will be considered, should be done, if you're thinking that they have pyelonephritis. If you have concerns about this being a recurrent infection or atypical symptoms, that's when you would get a urine culture. Imaging would be reserved for those that are quite different, serious, sick, ill, CT scan or ultrasound, or if they're not getting better after therapy, you'd be thinking about imaging. So can you diagnose your patients with a urinary tract infection with cystitis over the telephone? Of course you can. Cal Gupta did some landmark work on this even before COVID, where she showed that you can be effective, you can be proper, you can be evidence-based in diagnosing a woman with uncomplicated UTI over the phone. Typically, it's a woman that's known to your practice who has LUTs, typical symptoms. And typically, this is a woman who has already previously had cystitis, who says to her provider, hey, listen, my bladder infection's back again. I'm sorry to call you on a Friday night or a Saturday, but I'm out of town. I'm certain I got another bladder infection. Can you help me? And that's when it is proper, okay, to treat them over the phone. And now, of course, with telemedicine, we're doing it all the time without a urine analysis or a culture. And a study done by Cal showed that in a study of 172 women with a history of UTI, 88 women self-diagnosed UTI based on symptoms. The lab evaluations showed that 84% did have a uropathogen, 11% had sterile pyuria, and 5% were negative for pyuria and bacteriuria. But there was a high clinical cure rate, 92%, and microbiological cure rate, 96%, when you prescribed an antibiotic over the phone for your female patient who you suspected is having cystitis. This is another study, a retrospective study looking at 44 outpatient sites in 2018. Similarly, it showed that when clinicians were educated about guidelines, how to properly treat a urinary tract infection, and we're also had some extra tutorials on the importance of antimicrobial stewardship. Jim Johnson found out that these patients were more likely to receive a first-line antibiotic agent that was proper for their bladder infection, actually 75% of the time compared to 60% of the time of those who came in the office. And also, they were more likely to have followed the guidelines when choosing that antibiotic agent. They were less likely to have a urine analysis, of course, and they were less likely, though, to have a revisit with their clinician within 7 days of treating them over the phone for an uncomplicated urinary tract infection. These are the different guidelines looking at how do you diagnose uncomplicated urinary tract infections. The AAFP notes that the exam, again, is normal in a small segment of patients. Nitrites, typically positive, leukocyte esterase, and pyelonephritis. If it's suspected, you do urine culture and susceptibility. And actually, all of the guidelines, ACOG and ACP, they pretty much agree that CT scanning, imaging should be considered. Urine culture should always be done if you're considering pyelonephritis. Consider imaging, however, if you have a patient who is not getting better or does not improve with suspected therapy. And the American College of Physicians, although they do not mention how to make the diagnosis on physical exam, do also concur with the importance of getting urine analysis for nitrites and the like. ACOG, very similar as well. The IDSA guidelines on management of asymptomatic bacteriuria had two important points to make, I think. And one is that, well, first, the definition, presence of 1+ bacteria species greater than 10 to the 5, irrespective of the presence of pyuria, so you don't need white cells, in the absence of urinary tract signs and symptoms. And again, this is asymptomatic bacteriuria. This patient, this male or female, does not have symptoms, but has greater than 10 to the 5 colonies without signs or symptoms, that would be considered asymptomatic bacteriuria. And so this is a very common exam question, very common board question, and a very common real life scenario, because a very large percentage of patients receive antibiotics inappropriately for asymptomatic bacteriuria. Why? Because the urine came back, it showed nitrites, it showed leukocyte esterase, and the clinician said, like, well, I guess I better treat it. And so you don't treat asymptomatic bacteriuria except in 2 conditions. And those are, if it's a pregnant woman, you screen pregnant women in their first trimester for asymptomatic bacteriuria, and you treat them if they're found positive. And also men or women who are getting ready to undergo a urogenital procedure, during which time it is anticipated they may have bleeding from disruption of their urogenital mucosa. So I know TURPs are not a very common urologic procedure these days, but if a man was going to undergo a transurethral resection of the prostate, instrumentation through the urethra, blood is expected there, then a urine culture should be done prior to that procedure. If it were positive, it would be appropriate to treat that person for asymptomatic bacteriuria. You don't screen or treat anybody else. Premenopausal, non-pregnant women, diabetic persons, older persons living in the community or long-term care facility. These oldsters have a positive bacteriuria rate of at least 25% in the community. Older functional or cognitive impairment patients with non-localizing symptoms, very common. So in other words, a urine culture is done in a patient in the hospital who's admitted for a mental status change. But if they don't have localizing symptoms to the GU tract, they probably shouldn't get a urine culture done or treated for that, unless, one caveat is, if they're hypotensive. If you have a patient who is admitted to the hospital with delirium, recurrent falls, who's found to be hypotensive, that would be an indication for screening for asymptomatic bacteriuria or screening for infection and then treating and then figuring out what's going on later. But too often patients in the hospital are getting antibiotics for asymptomatic bacteriuria. Solid organ transplant recipients greater than 1 month post-transplant should not get a urine culture, should not be treated. And patients with indwelling urinary catheters. 100% of patients with an indwelling urinary catheter after 30 days will have greater than 100,000 colonies in their urine bag. Okay, asymptomatic bacteriuria, inappropriate treatment. Studies have shown that 83% of those treated with antibiotics for a median of 7 days. Who got treated with those antibiotics? The older patient who's demented, maybe with an acute mental status change, urinary incontinence, leukocytosis, positive UA, urine culture, they got treated. Antibiotic treatment is not associated with improved outcomes. However, it is associated with longer hospital duration after urine testing. These patients typically are in the hospital for 4 days versus 3 days in being evaluated, screened, and treated for asymptomatic bacteriuria. A decision tree to consider whether to treat or not treat. Well, certainly is the patient symptomatic? You shouldn't send the urine off on somebody unless they're symptomatic. But if the patient is symptomatic with dysuria and frequency and urgency, and maybe they have suprapubic pain or hematuria, maybe not. But certainly if they have fever, rigors, altered mental status, delirium without an alternative diagnosis, then consider urine analysis, consider the culturing of this patient. And if this is positive, again, you consider a diagnosis of cystitis pyelonephritis. If that oldster in the hospital has mental status change, delirium, and hypotension, you would look to screen and treat. Or if they had symptoms that are localized to the genitourinary tract, if they happen to tell you they had dysuria or frequency, then yes, that would be very appropriate and you might be calling them having cystitis or pyelonephritis and treating them. Versus if they don't have what I just mentioned, then they'd be called asymptomatic bacteriuria and they would not receive antimicrobial treatment. This is just a busier slide that says pretty much the same thing for those with non-recurrent cystitis. If you suspect cystitis and they don't have signs of vaginitis or prostatitis, then consider that they may have a UTI, and that's when you can designate them as having non-recurrent, simple, uncomplicated cystitis. You'll send the urine for microscopic. You'll confirm with leukocyte esterase and treat with antibiotics if appropriate. And if they're better after 48 hours, you're done, right? But if they don't have these UTI, lower urinary tract symptoms, you're not going to screen or treat them, okay? An important question for women with LUTs, lower urinary tract symptoms, is if they have vaginitis. If they're having vaginal irritation or discharge, think as well, could this be an STI? Remember, presence of vaginitis is a kind of a factor that goes against it being cystitis. Doesn't mean they couldn't have cystitis, but it's something that goes against them having cystitis. And that's why I always ask the question about vaginitis. And this is a similar algorithm for recurrent. And basically, the decision tree is very much the same as I just mentioned to you on the previous slide. Treatment failure definitions include unresolved symptoms, where a patient calls back a couple of days later, says they're no better. They may cite a need for a new antibiotic prescription, or may go to an emergency room after seeing you, or suffer further complications. Treatment failures are significant. Worldwide, 10 to 18% of patients with uncomplicated UTI treatment are treatment failure. Recurrent UTIs, 20 to 40% of women with cystitis are likely to experience additional episode, and up to half of these patients will experience multiple recurrent episodes. The risk factors for treatment failure include older age, frequent sexual intercourse, use of spermicides, urinary incontinence, cystocele, and vaginal colonization. And this is a study looking at uncomplicated UTI treatment failure, risk factors, and subsequent outcomes. I'll just say that patients with non-susceptible isolates, more than half of them were likely to receive a new antibiotic. So treatment failures are important. Looking at risk factors for recurrency are important. And that's a theme of this talk, which is when you see your next patient with a bladder infection, in addition to asking, is this uncomplicated or complicated? Undercomplicated, I think you'd have to include the category of recurrent urinary tract infections. So one of the first things I do when I make the diagnosis of a bladder infection is I talk to the patient, look in the chart to see when was her last infection, how often does she get these? If she's just had an infection 3 months ago, then maybe what she's suffering from now is a refractory infection, one that is resistant to the antibiotic she got 3 months ago. And what I'll typically do in most women is change the antibiotic to something different if I think she's got a bladder infection today than what she was given 3 months ago, because she may well be resistant to that which she was given 3 months ago. So take-home points from my small segment here is uncomplicated UTIs are common infections that carry a significant burden for our patients in the healthcare system. Collecting a thorough and accurate history is essential to decrease the burdens. Partnering with patients via telehealth and or virtual visits can improve health-related outcomes in treating uncomplicated UTIs. And healthcare professionals should avoid screening for and treating asymptomatic bacteriuria in most patients.
I'd like to thank Dr. Colgan for that excellent discussion, and thank you to our listeners for joining in. As a reminder, to view the slide set for this podcast and to access the full program on Uncomplicated Doesn't Mean Easy, Recognizing the Burden and Preventing Treatment Failure of Uncomplicated UTIs, click on the links in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.